Welcome once again to another session of the liver transplantation series on the LGS forum. Tonight we will dive into the deep end of liver transplantation, the recipient operation itself. As we all know, the outcomes of liver transplantation have improved dramatically over the last 2 decades. And one of the most important contributing factors to this overall success is the refinement and standardization of the surgical procedure. Although still a complex task, technical advances have transformed the operation from an experimental undertaking to a therapeutic procedure, and one that is within the capability of any competent surgeon. More importantly, it is now an operation that is practical and can be replicated on a large-scale basis. Since the pioneering times, innumerable changes have been made which has transformed the transplants surgery into what barely resembles its ancestor. But what remains constant are the 4 basic stages of any transplant procedure: the donor operation, which we discussed in the previous sessions, the recipient hepatectomy, the implantation of the graft with at least 3 vascular anastomosis, if not more, and last but not the least, the hemostasis and the bile duct reconstruction. Now, the recipient hepatectomy, or explant as it is called, represents the most difficult and crucial stage of the entire liver transplant procedure. Numerous battles have been lost in the first 2 hours of this surgery. But the key secret of this operation, as should be for all surgery, is to have a complete mastery of the anatomy to avoid wandering into places or structures where one is not supposed to be. Even the most minute, careless move can have a devastating impact on the outcome. Of course, nothing supplants experience and technical expertise for the final result, and one cannot overemphasize the need for precise atraumatic dissection. A ponderous, hesitant move can invariably result in greater bleeding and more complications. There is no single best method to remove the diseased native liver. Tips and tricks abound, and so do numerous devices to aid the operation. To give us an overview of the principles of the explant hepatectomy and the DDLT operation tonight will be the first speaker, Dr. Ilango Sethu. He is a transplant surgeon at MIOT hospitals and is one of the founding pillars of the LGS forum. Having done his basic and higher surgical training in India, he did his transplant fellowship from Pittsburgh in the United States. Dr. Ilango is highly published and often invited speaker at GI surgery and liver transplant forums and conferences. Now, to make matters even more complex than a DDLT operation is that there are numerous other nuances to an LDLT operation. It's not only half the liver and smaller and more number of vessels which need suturing, but an implicit understanding of the portal physiology is imperative and lies at the heart of a successful LDLT operation. To educate us on this is Dr. Srinivas Reddy. He is currently the Director of Liver Transplantation Services at Global Hospitals. He is one of the brightest brains in the business with a keen clinical, surgical, and statistical acumen. Having done his basic surgical training in India, he followed it up with an FRCS in transplant surgery in the UK and a PhD on preservation techniques for the pancreas. Dr. Reddy then returned to India to be part of Professor Ella's team from Jan 2012 till recently. He has over 140 publications and numerous book chapters, including a co-authored book chapter in Gray's Anatomy with Professor Ella. He's also a member of the pediatric committee of the ILTS. I could go on and on about him, but before that, over to you, Dr. Ilango. The stage is yours.
Thank you, Ashwin. Is my screen okay?
Yes. Yeah.
Yeah. Yeah. Thank you for the opportunity, Ashwin. Sorry. Yeah. My first disclaimer is that I am a shameless copycat, and I have used others' hard works, and I have simply copied them just to make my surgical life much more easier. So I'm not claiming anything original here. I have copied from pretty much everyone I have seen in the last 20 years of my surgical career. So my thanks to all of them who have trained me and taught me. So most of the techniques which I'm going to describe here are what this man in the middle taught me, Dr. Humar. It's now 6 years since I have worked closely with him. And you can see that even as late as August 2020, he still keeps sending us gentle reminders, discusses clinical cases, and keeps us going. This is Bodhi, who was my colleague. We were one of the 2 senior most guys accepted for a liver transplant program at that time. We were 42 and 43 respectively. Usually people tend to take younger ones, but that particular year, Huma made a decision that people should be capable of operating independently. So he took 2 senior surgeons to do this transplant fellowship. So this was one of his last photographs, which he shared with me on WhatsApp. Now, here are the goals that I usually look for in a good DDLT. I want to do a total hepatectomy with minimal blood loss. I want to have a very short anhepatic phase, usually around 90 minutes. I have a physiologic goal of a portal flow of at least PSV of 40 centimeters per second. The hepatic vein triphasic in all the veins, I try to achieve that. And hepatic artery flow PSV of 48 centimeters per second. And in the peripheral of the liver with an RI of 0.6, a good bile duct anastomosis. The goal is no leak in the perioperative phase, and an alkaline phosphatase of less than 126 in males and 96 in females. Stall calling. Little, small, or minimal or mild reperfusion syndrome. No early allograft dysfunction, no PNF, and no ACR in the first 90 days. So this is how I see the first 90 days of a good DDLT. Now, a cadaveric liver transplant to achieve these goals has 4 phases: the explant, the assessment post-explant, the connections, and the completion. The connections itself consists of 4 phases: hepatic vein outflow. Someone's mic is on. There are 4 connections: hepatic vein, portal vein outflow, portal vein inflow, the hepatic artery outflow, hepatic artery inflow, and the bile duct outflow. So before I go into the surgery, this is how, this is the mind map of the graft readiness. Someone's mic is still on. Can that be turned off? Ashwin?
I think it's with Patasa to turn.
Yeah. Okay. All right. For the graft readiness, we look into the outflow readiness. There are 2 aspects which I see: the connection site and the venting site. Depending on the technique of reconstruction, I look into the different aspects of the connecting site. If I'm doing a classical piggyback, I look at the top, clean the diaphragmatic attachments. I make sure the phrenic veins are closed, the atrial muscles are removed, and the edges are clean. If I do a side-to-side cavostomy, I look for a clean posterior. In the initial phase of my training, I used to avoid this technique in livers with caudate lobe wrapping, but now I'm more comfortable in dividing the caudate lobe and still doing a side-to-side cavostomy. I do a 6 to 8 centimeter cavotomy with the topmost end close to the 3 hepatic veins. And I make it just before implantation. So I check whether it is suitable for that. Sometimes I do both the top and the side preparation if I'm doing an end-to-side cavostomy. There are some circumstances in which we end up with large for size grafts. So we usually use a vein for jumping for an inferior terminal cavostomy. The venting site on the lower end of the donor vena cava has an open part and a control part. The open part is made on the right side. So the open part is made on the left side with a single stitch for control. And the control part has a closed portion which we close in 2 layers with fluoroproline, so that the venting hole is really small. There are lots of people who leave the venting site completely open and tie the lower end of the vena cava with a silk tie, but we are much more comfortable with what we are doing so far. The portal inflow readiness, we look for the length, adequacy of the length of the portal vein. Usually in a DDLT, it is quite good. We look for dissection holes and close them on the back line. And sometimes we leave a flush line so that the preservative solution can be easily flushed out during the implantation. The hepatic artery readiness is checked by looking at a single site for anastomosis, either at the GDA branch patch level or at the common hepatic artery level or at the celiac axis. Right now we are doing most of our DDLT with the celiac axis. We look for intimal cleanliness. And again, we check the vent site and we allow a length for clipping. Sometimes after reperfusion, Pari checks for the test called the artery test for Ajita. And the last one is the bile duct. I have left it plain because we actually don't do anything with the bile duct on the graft. The key thing for a youngster to understand is that the explant operation is the transplant operation. You can actually get yourself completely assessed when you're a trainee by the way you do your explant operation, and pretty much most of the connection opportunities come from the way you do your explant operation. So you can do a completely bloodless operation or it can be a bloody mess. There are quite a few variables that go along with it. Some of the things which we see is the history of pancreatitis or spontaneous bacterial peritonitis in the past, especially if they have more than 2 or 3 infection episodes, and they have thickened peritoneum. When you see large collaterals on the CT scan prior, especially if you have a tendency to wander off from the correct tissue planes, that's another place. If you have caudate lobe wrapping around the vena cava, that is another place where you can have a bloody operation. But as you grow in seniority and you develop more experience, your capability of doing a bloodless operation keeps on increasing. Last part is connection site readiness. So that is another thing which you have to see after the explant. For incision, there are quite a few incisions that people use for doing a liver transplantation, but for a trainee or a young surgeon, it is good to practice one standard incision very well. So the incision in which I was trained is the Mercedes-Benz advocated by Roy Cullen. So this is the notes from my training time. So we usually make a shorter cut on the left side, which stops at the lateral border of the left rectus. And we stop at the curvature of the ribs, beyond which it yields no benefit. So, and a retractor setup for a comfortable surgery. This is Dr. Hughes' setup, so which we still continue to follow. The body walls on both the sides, the sweetheart for the hilar retraction, the malleable for, and the 4 fingers for the colon and the stomach retractions. So this is probably another trick that the trainee must learn very, very well to set up the retractor very comfortable for the surgery. So a good setup of the retractor will help you do a smooth and comfortable surgery. For the liver explant disconnections, I have divided them into 3 parts: the ligamental disconnections, the hilar disconnection, and the cable disconnection. Each one of them has its important role. Falciform ligament has a bunch of collaterals usually, which we remove completely along with that, with the anterior part of the falciform ligament. The right triangular, left triangular ligament, the gastrohepatic ligament, the hepatocaval ligament, and sometimes what we call as the bloody gulch of Tom Cacciarelli on the left side of the inferior vena cava. So these are the places where we usually disconnect. The hilar disconnections, which we will discuss in detail. The cable disconnections are 2, the short hepatic veins followed by the main hepatic veins. Post-explant, we have two important sites of control. The bloody gulch of Tom Cacciarelli, who taught me that this is the left side of the inferior vena cava, which usually has quite a bit of bleeding. But most of the bleeding which I found out was from the site where the left triangular ligament, the ligament venosum, and the cortical, they converge together to form a thick and vascular tissue, usually contains the left phrenic vein as well at that spot. So we use aquamantis to control the tissue bleed in US, but here we use a couple of stitches to control the bleeding. So that's one place. The second place where we make common mistakes is going into the right adrenal. So that also can cause a lot of irritating bleeding, if not a lot. So the ligament disconnection, some of the key lessons which we do is docture around the round ligament. So you have to find the right plane. You have to take down the anterior portion of the falciform ligament so that the entire collateral bunch at the round ligament comes off in your own hands. The left triangular ligament has a very standard way of taking. You place a pack under the left triangular ligament, and you can see through the translucent left triangular ligament, and you can take it off. You can watch for the vessels at the tip of the lateral segment, which you can control with some energy devices. The gastrohepatic ligament is not taken down with either any energy device. It's usually ligate and divide. We do have collaterals, and it's a very simple technique to do. That also reduces the amount of bleeding on the left side of the cava post-reperfusion. The bloody gulch, like I said, on the left side of the vena cava, you take down with cautery, and the left side short hepatics are ligated in continuity and divided. The right triangular ligament, the simple technique is to go from apex to the base on the right border of the vena cava. So if you go slicing on the surface of the liver without going into the liver capsule, usually you stay safe. And a good traction, counter traction on the diaphragm and the liver will keep you in the safe plane all the time. And I always leave a layer on the adrenal so that the plane actually goes just between the adrenal and the posterior border of the liver. So it's not a very difficult one. You learn to do it in a couple of cases when you start doing a explant. For the Hilar disconnection, there are a lot of people, this is my technique. I usually take down the cystic duct. The right border of the hepatoduodenal ligament is divided by placing the cystic duct on traction so that I can get behind the CBD or CHT. And the anterior portal plane can be usually cleared with a peanut. This gives me access to the right artery in the duct and then to the left artery in the duct. So before I tie the artery, I always put a bulldog on the artery before I tie it so that I reduce the risk of dissection in the artery. And once this is done, you clear the posterior part of the portal vein, which the fatty layer that lies on the posterior aspect of the portal vein. Once you do that, it's very easy to loop the right and left portal vein prior to going in for the hepatic phase. So we usually leave the portal vein intact at this point of time and then focus on taking down the short hepatics and the hepatic vein. There is no difference in the way we take up the short hepatics between a liver transplantation and a standard hepatectomy. But sometimes the right hepatic vein has a vertical orientation. This is much more common in what I have seen. So I usually take the right hepatic vein separately with an endo-GIA stapler, like it's seen. And then you can apply a transverse vascular clamp on the left and middle hepatic vein branches. There is, like I said, there is no difference in the way you take the short hepatics in a standard right hepatectomy. Post-explant, I usually do a bleed control, a couple of rounds to see that I have not missed any collaterals. Usually see that the knots on the short hepatic veins are secure. So I look at the vena cavas. My training technique was that the anterior surface of the vena cava was prepared. We never completely circumferentially dissected the vena cava. So I'm still comfortable doing that. But sometimes when I have to clamp the cava completely, I make sure that I have a circumferential clearance. The portal vein preparation. This I make sure that the right 3 o'clock and the 9 o'clock positions are identified, which is usually at the level of the pancreatic head, pancreatic neck. And so I usually clear off all the tissue on the surface of the portal vein and make sure I have a good length. As a matter of practice, I still do the high hilar dissection for the bile duct. So if there is some bleeding on the bile duct, control it with a couple of stitches of Prolene. So the assessment is to look for the graft fit, which probably is a little late at this point of time, but even then it is good to look at the graft fit and then prepare for the alternative outflow reconstructions. I look at the hepatic veins for the cloaca assessment, whether the upper lip and the lower lip configuration, whether the upper lip is lower than the lower, is smaller in size compared to the lower lip. This is the best kind of cloaca. Or if the upper lip is larger than the lower lip of the cloaca, in which I will be forced to do end-to-side cavoceostomy. Or if both the lips are small and likely to slip, I usually suture them close and go ahead with the cavoceostomy. The right hepatic vein vertical orientation, my standard technique is to staple close the right hepatic vein, close the middle and left. I don't usually use those two veins. I convert them into a side-to-side cavoceostomy. The IVC is assessed on these factors. We look for narrowing, we look for thrombosis, we look for a torn IVC, badly torn IVC, probably will require a classic technique, and also look at the secured short veins. We also look at the portal vein for length, flow, the diameter, and the thrombus. The diameter, whether it is smaller than 7 millimeters in adults or 4 millimeters in pediatrics. We're talking about DDLT here, so we'll stick with the adults. So the key diameter to note is 7 millimeter. On the hepatic artery, we look for length, flow, a pulsatile flow. There is no respiratory variation. The diameter to find out the appropriate connection site, and to look for dissection. We also look for the suitability of the bile duct length, but in a DDLT probably it does not matter. But I still go ahead and look for it because we've had a couple of times when we had tension on the bile duct because the bile ducts were cut short on either side. There are teams which do temporary portocaval shunts in order to provide hemodynamic stability to the recipient during the anhepatic phase. It is associated with fewer RBC transfusions. It is associated with fewer biliary complications, and it's associated with better 3-month graft survival. But we don't do a temporary portocaval shunt in patients. But if we have too much bleeding from collaterals, or if there is bleeding into the GIT from varices during surgery, a temporary portocaval shunt is a great help. Now the connections, this is the connection mind map. So we have the outflow reconstructions. So the outflow reconstruction has the classical vena cava replacement technique, the classical piggyback technique, the side-to-side cavoceostomy, the cavoplasty, which is the end-to-side cavoceostomy. And sometimes when you have complicated outflows, I have these 3 salvage procedures where I use a dual outflow, a double vena cava outflow, or sometimes an infraterminal cavoceostomy. So these are these mind maps were prepared for me to actually pick up techniques. So I'm sharing them with you all. It may not be useful for everyone, but it's a good general basic plan. For the portal flow, the standard inflow is a portal to portal anastomosis. In a portal vein thrombosis, you can do an eversion thrombectomy, an aerial grade 3 SMV portal vein jump graft, or sometimes you can do a renal portal anastomosis or cavoportal hemitransposition in pretty bad situations. Like I said, we look for a diminutive portal vein, and we are very, very particular about portal flow when the size is less than 7 millimeters in adults. And for if there is poor portal inflow after we reconstruct the portal vein, we usually assess by a Doppler ultrasound, and we do collateral ligation to increase the portal inflow. The hepatic inflow, there are two different components which we have to see. The landing site is either a GDA branch patch, the common hepatic artery, the celiac artery branch patch, and sometimes you may have to do something with the replaced right hepatic and the replaced left hepatic vessels as well on the donor. So how you reconstruct also you have to plan. The recipient link site is usually at the common GDA branch patch, the common hepatic artery, and sometimes you may have to go do a jump graft from the aorta, from the supraceliac aorta, or at the infrarenal aorta. Sorry for the typo. And the bile duct outflow is reconstructed as duct to duct. So there are the other things doesn't matter, or a hepaticojejunostomy. So the 6 different techniques which we use here are the piggyback, the side-to-side cavocestomy, the end-to-side cavocestomy, the modified passing loop technique, which we have called as the double vena-cava technique, or the dual outflow reconstruction. These are for situations where you have a large graft and you end up with a large cardiac load. So these are the 2 situations, or the passing loop technique. We have not done any classic vena cava replacement surgeries during the time I have been a transplant surgeon, but it is advised still for patients who sustain extensive caval damage during an explant. There are a few critical features that you should remember during the Outflow Connect protocol. So for the classic one, I call this SIPA sequencing, which is superior, inferior vena cava, portal, and arterial sequencing. For the piggyback, like I discussed earlier on the mind map, you should know the lower lip length. That's the key. It should be longer. So the way you cut the cloaca, you have to make sure that the lower lip is of adequate length for you to get an imbricated suture. The clamp siting is very, very important. The clamp should actually sit on the vena cava, but it still must be capable of emptying. There are a few choice for your clamps, but most of them, as a general rule, have a good bite capacity, the bite strength on the middle of the clamp, and the tip is usually weaker. So if you feel that the clamp is slipping, you must have an alternative, a bigger size clamp for you to get control of the bleeding. A side-to-side cavocestomy, the good length is set to be 8 centimeters in length. We close the upper and close to the hepatic veins with fluoroprolinol and 22 mm needle. End-to-side cavocestomy is when you have lip discordancy, that the lower lip is smaller in length compared to the upper lip of the cloaca, and you can extend a cavotomy. Some people call it a cobra anastomosis. This is also a very good technique to learn. The other things are probably not needed for a training. We can discuss this if somebody has a question. Now, a lot of people have studied this, but the good thing to know is the piggyback and the side-to-side cavocestomy is associated with a reduced warm ischemia time, reduced blood loss, and it's a very good technique for a trainee to learn. It's associated with reduced implantation time. Some of them do synchronous portal and arterial reperfusions when they use side-to-side cavocestomy. So we also, there are also studies which show a reduced vascular complication in side-to-side cavocestomy compared to the piggyback group. And the rest probably are statistical gimmicks. But one thing I know for sure, this is the side-to-side cavocestomy is just like the renal vein anastomosis. So anybody who goes through a DDLT program with the training in kidney transplantation will find it very, very easy to do. Now, when I look at the hepatocaval anastomosis in a DDLT, I have 3 steps to make my decision. Now, step number 1 is how is the configuration of the hepatic veins? So I look for an adequate common cloaca with all 3 hepatic veins. So I make sure I have 3 hepatic veins for my piggyback anastomosis. If there is no adequate common cloaca, I just close off the cloaca and do a side-to-side cavocestomy. If the piggyback is possible, I check for the lower and the upper lip of the cloaca. If the lower lip is more in length compared to the upper lip of the cloaca, we do a standard piggyback. If the lower lip is smaller than the upper lip, I go for an end-to-side cavocaveostomy. Both the lips are very small. I just close off and then do a side-to-side cavostomy. And sometimes I operate in other places. I feel I don't have a safe assistance or clamps. I just go ahead straight for a side-to-side cavostomy. I find it much more comfortable because of its reproducibility. Now, in a classical piggyback anastomosis, this is one of the most difficult technical issues in a DDLT. It's because of the narrow axis angle, which we'll discuss subsequently. We have to use a larger needle. Some of them use, in big people, they use an SH needle, 26 mm, half circle, or an SH1, which is 22 mm, which is our standard needle. The piggyback needs a continually variable needle tissue angle. So it's like a spoke in a wheel appearance, so that you get a widest anastomosis possible on all parts of the anastomosis. If you don't do a very good cloaca preparation, you will end up with a lot of ragged endothelium. So it does not seem to matter, but you will end up going more higher up and you will have a much more narrower outflow, and you may end up having a butt chiari or an inadequate outflow in the liver. So you have to hit the right lip length and you have to get the right outflow diameter. So you have to use the largest part of the cloaca as much as possible. Now, if you look at the working angle in a piggyback anastomosis, there is a fixed part comprising of the diaphragm on the upper part and the liver upper surface. The anastomotic area lies close to the retroperitoneum, so it's quite deep. So the angle becomes narrower when you have a stocky person, a big build person, and the liver upper surface moves upwards because of the larger size of the liver. So the anastomotic angle is like this. So the deeper the D line, if the diaphragm is quite deeper and larger the liver, the angle will narrow and you will have a difficult technique. Now the piggyback suture line, there are a few things. I mean, it's very hard to teach this on a lecture, but for those who are interested in learning this, there are a few tips and tricks you can learn. The piggyback suture line scheme, this is the left side of the patient and the right side of the patient. This is where your standard piggyback suture line starts. So what we do is we place the left suture line so that you can suture towards yourself. You place the stabilizing suture on the right side, and you always divide the anastomotic line, the suture line, into two halves by placing another suture in the middle. So you can imbricate it by taking the endothelium on both the sides so that you have a perfectly everted anastomosis. So you can shift the tension on the suture line. So that's a clean way of doing a piggyback suture. In case you have a large liver, there is an alternative technique, almost similar to what you use in an arteriovenous fistula creation, which is Tellis technique. So you take two 4-0 prolines, take off the needle side, you have 90 centimeters of suture line, you can tie it in the middle, and you could start at the middle, and you can use just like how you do a parachuting technique. In a large liver, you can still do a piggyback technique. Two surgeons doing this can complete that anastomosis in about 12 to 15 minutes. And you can still have a very secure line, even in deep patients. So the posterior suture is always imbricated and the anterior is non-imbricated. So that when you see the anastomosis will tip open very well. And it's reflected in the postoperative Doppler when you see a classic good triphasic waveform. There are some questions about people, how many veins to use for a piggyback anastomosis. Like I said, my whole training was with 3 veins. I have never used a 2-vein anastomosis. The reason being a lot of people in Pittsburgh believed in these studies published way back in 1999. The last one was from 2005. They looked at 2-vein and 3-vein anastomosis, and the 2-vein anastomosis was inferior in most of the studies. So it was associated with intraoperative venous congestion, the liver being firmer, and it was associated with acute and chronic butt chiari syndrome, and everything is pretty much the same message. So Our classic is we use 3 veins. If we cannot use 3 veins, we go for the side-to-side cavostomy. This is how the best way to learn this is by doing it once. It's quite easy, or looking at renal vein anastomosis in a renal transplantation. It's a very good YouTube video by Chris Sonande from the University of Michigan, and you can see the good cut. This still is they have divided the caudate lobe, and you have to cut at least 6 to 8 centimeters of cava to get a good anastomosis. So what we do is usually the surgeon standing on the left does the cavostomy. The working angle is extremely easier for side-to-side cavostomy. It's close to 90 degrees. Some of them even more obtuse. So the left side technique is we tie the south side stitch and we place the north side stitch as a stabilization. And we use a standard renal vein anastomosis, go to the posterior wall and then follow up to the anterior wall and finish the suture in the midline. Sometimes when you have an inexperienced surgeon and you have to do it from the right side, I usually tie the north side stitch tie and start the suture from above, and I use the south stitch as a stabilization. It's almost like doing a right hepatic vein anastomosis in a living donor liver transplantation. The third variation I do is sometimes in the south, when the left side surgeon starts and I have to do it, take over, do the south side tie, you sew from below upwards. This is a technique I learned from Professor Mohammed Rela. This is something recently I learned. The fourth one is to use a modified Tellis technique for the left side surgeon. So if there is difficulty in keeping the anastomotic edges open, I usually take the stitch in the middle and go all the way around, just like how I would do in a AV fistula. So the venting site is the same. The venting site remains on the lower end of the vena cava. We always finish the suture line. So this is how it looks like. The back wall of the anastomosis is complete. The transplant cava is splayed open. Our anastomotic line is still quite big compared to this. For the portal vein, the key rules to remember is that we were taught like this. It should be appropriate tension, no twist. So I usually call this the AT&T mnemonic. So before you do the portal vein anastomosis, you have to flush the portal vein first. There are 2 techniques. Like I said, for every surgical technique in transplantation, the minimal number of techniques that you should learn is 2. And as you go up, you can build up on that skill set. So I call the AH or the AT technique, which is the standard technique. The posterior is done from inside. It is a 3 o'clock to 9 o'clock suture line. And the Crispy Hughes technique is all done from outside, but the suture line runs from 12 to 6. And there is a 90-degree twist on the portal vein when you do the anastomosis. So this is how I do the twist prevention. The key is to define the clock face on the portal vein segment. So I go as low as the portal pancreatic neck, and you find that the 3 o'clock is actually dipping on the lower side, on the left side. So you have to place the clamp at the appropriate angle to find out the exact 3 o'clock position. So on the donor, I usually follow the inferior border of the LPV and continue with the left border. And this is quite easy to find out. You don't have to. Small errors are okay. It's just that I'm very particular about these things. On the tension, you have to get the right tension on the portal vein. If you get too tense, you will get larger needle holes and there is a tendency to tear the portal vein. And if it is too lax, you get an angulation and kinking. So to get the right tension on the portal vein, we put 2 cold wet packs under the liver above the diaphragm. So the liver is shifted below. We clean the vein, we cross the vein, and then we cut the vein. So that there is a slight laxity. We don't have tension when we are actually doing the anastomosis, but when we take off the 2 wet packs, you get the right straight portal vein. So this is how we do it. We start on the left side. This is the recipient portal vein, the castrated or the pediatric angle pot clamp. You have the lateral tension stitch. This is probably an unnecessary stitch, which you see in the middle. You can see the anastomosis is slightly everted. you have a good endothelial bite. So you must have a slight ridge on the posterior wall. The bite hole must be very good. You have to mind the bite direction in the suture line. This is something you will learn over time, so that the suture line lies vertical to the cut edge of the portal vein. Nowadays we do in situ flush, but when we were in training, we were trying to do the ex situ flush. Before we bring in the liver, we usually flush with saline. Some of them use 5% albumin. There are people who use room temperature saline flush as well. Or you can do whatever you are suitable and comfortable, what is suitable for you and comfortable with. The last, when you finish, is how much growth factor to leave. Is the greater the portal hypertension, the bigger the growth factor. So we have large varices or a large spleen or plenty of ascites, we usually leave a bigger growth factor. There is actually no defined one. Some of them leave almost 100% of the growth factors. Once you have done the saline flush, the only thing that is left after this is a blood flush, and then close the venting site, so you're ready for reperfusion. Normally an anastomosis for me takes about 12 to 14 minutes. So I have this 7-minute call. So right before reperfusion, we ask the anesthetist whether they are ready. So these are the parameters I look for: the hemodynamics, the CVP of 5, a cardiac output of 5, a MAP of at least 60, and a heart rate of 60. So that's the hemodynamic parameter. We look for the hematologic parameter: hemoglobin of 7, platelets of 40, a fibrinogen of 100, and the MA of more than 45. That was in Pittsburgh. We no longer do it. The electrolyte, a calcium loading up to 10, a pH maintained more than 7.2. And if we used to have very young anesthetists or cardiac anesthetists, we always tell them don't give potassium just prior to reperfusion. The other teams also prepare defib pads. They have TPA in the room. They discuss anesthetic readiness by having the senior anesthetist. Sometimes they have echocardiogram, transesophageal echocardiogram ready. These are all dependent on unit by unit, but this is the general rule. The more experienced the anesthetic team you have, you probably don't have to look at it as when you have a young team, and these are simple parameters for you to remember. There are several types of revascularization techniques in clinical liver transplantation. The most commonly used is the sequential revascularization, where we do the initial portal reperfusion followed by the hepatic artery reperfusion. There is a retrograde reperfusion by the inferior vena cava, which I have never done. The simultaneous revascularization by the portal vein and the hepatic artery in some experienced team, where you're able to do a quick anastomosis on all the 3 vessels. So that's a tall calling, but some of them do achieve this. It's a simultaneous revascularization. So we do know that if you do a simultaneous sequential reperfusion, some part of the liver remains ischemic. The most common one we do is the initial portal reperfusion. The bile ducts are at higher risk for ischemia in this situation. Sometimes when you reperfuse and you have more bleeding to control, and you take a longer time, you want to take a break, all those things can increase the risk of biliary complications. So it's good to go in for the arterial reperfusion quickly after the portal reperfusion. The best way to keep your biliary complications low is to do a simultaneous arterial portal reperfusion. I told you that I have never done a retrograde vena cava reperfusion, but there are some studies which show the graft dysfunction was quite low in these cases, but I have no experience in these things. But whatever type of reperfusion you do, it is not associated with patient. It makes no difference in your patient or graft survival in either of these techniques. Once you have a hemodynamic stability, and sometimes even without that, you have relatively good control of the bleeding, you can go ahead for the arterial reconstruction. The best site for an arterial reconstruction is the common hepatic artery to common hepatic artery. The common hepatic artery has a good thick tissue, the bites hold very well, and the interrupted sutures are quite easy to place. The orientation of the vessels is very good, so they are the best. The branch patches are very easy to teach, so I think most of the trainees and young surgeons follow the branch patch techniques, but the branch patches are actually thin and they can cut through easily if you're not very careful. There are times when you have old grafts. Our oldest one is 83. We are usually careful to avoid those with atherosclerotic blood vessels, but sometimes you may end up. If you have very hard vessels, we use Gore-Tex sutures, which has a much stronger needle, and the drag through the tissue is quite easy with the Gore-Tex suture. Our standard suture for the hepatic artery anastomosis is 6070. The right orientation you have to allow for twist is to orient the GDA to the 9 o'clock position. Large vessels you can use a continuous anastomotic technique. There are two different vessel placement, suture placement orientation. Either you can do a 12-6 or a 9-3, whichever you're comfortable with. We follow the 12-6 so that the twisting is just halfway across. We also use the interrupted suture technique with the same orientation. This is a diagrammatic picture. This is from Starzl's old paper. So this pretty much is what we're doing all the time. Even though this appears larger, actually when you see the anastomotic, probably your suture line will completely close here and the lumen will remain small. So it's not that you're going to narrow the anastomosis. You're going to do you're going to avoid narrowing the anastomosis when you do a branch patch anastomosis. So one of the salvage techniques a good surgeon in liver transplant should know is the placement of an aorta hepatic grafts. This is something you have to learn, especially when you go alone for the first time. You have to check this toolkit every time along with your grafts to make sure that you have good iliac arteries. You prepare the aortic site, bowel up to the right upper quadrant, ligament of Pride's exposure. You expose the aorta below the renal vein, ligate lumbars. You clamp the aorta with a good Setinsky. And in US, we're using the 6 punch. I'm using is 4.8 punch in India. The tip for the suture technique in an aorta hepatic graft is to go inside out on the aorta. You have to take a bigger bite on the aorta, but a closer bite. You have to cross over at the finish so that the suture line goes across. And parachuting is a good skill to learn here. So this is one of the salvage things, because if you will find out a dissected hepatic artery quite late in your surgery, and you must always be prepared to revascularize through the aorta hepatic graft. The last bit, probably after a round of hemostasis, the bile duct anastomosis. If you have done a good explant, if your anastomosis is secure, your bile duct anastomosis will follow almost immediately after your arterial anastomosis. But here, most of the time, we usually take a break, run through the hemostasis quite well, and then do the biliary anastomosis. There are two standard techniques of bile duct anastomosis, which is the duct-to-duct anastomosis and the hepatic ogygenostomy. On the duct-to-duct anastomosis, again, we have two different techniques. The Todo technique, where the ties are all outside, and the Voyle-Kelly-Blumgart technique, where you have a posterior luminal knots and the anterior knots are outside. The bile ducts are usually small sized or relatively larger sized. So there is no exact definition of that. So our standard numbers are between 9 and 11 sutures. We use 60 PDS. I'll just go through the Todo technique before we close. And there are quite a few variations what to do in a size discrepancy when you have tension or ischemia. Obviously, with a lot of tension and a short duct, you just go ahead and convert into hepatic ogygenostomy, or if you have an ischemia, you convert to HepJ. The size discrepancy, you can spatulate, you can do a side-to-side cut, and then manage This is a simple Todo technique diagram. We place two sutures on the posterior aspect, 1 and 2. It's actually wrongly labeled here. The first suture is placed towards the assistant side from the right side, and the second one is towards yourself. And the third suture is placed anteriorly. And then the duct is twisted, and then you can place 3 on one side, and then move to the other side and complete the 3 sutures on the next side. You may go up to 4 on either side, so that means about 11 interrupted sutures. This works very well for us. The last completion checkup before you complete your DDLT is to look at the liver consistency. It's usually a good, well-done transplantation with probable good outcomes. Will be soft, feels like a baby butt. The on-table Doppler, I'm quite fond of this. a hepatic vein PSV of more than 10 centimeters per second, triphasic or biphasic flow, I do it myself. A portal vein PSV of more than 25 centimeters per second, no phasic variations. A hepatic artery PSV more than 48 centimeters per second, a good diastolic flow, an RI of 0.6. I also look for bile staining on a 4x4 gauze, which I leave for some time. One of the key rules is that if the patient has a hypotension and you have ongoing bleeding, don't attribute it to coagulopathy. There will always be a bleeder. It is not good to take those patients out of the operating room. You will end up bringing them back and re-exploring them. So hypotension and coagulopathy, they are not, coagulopathy is not usually associated with that amount of bleeding to cause hypotension. You will invariably find a bleeding vessel. So we place 2 drains conventionally. Once we close up the abdomen, we go and do the W2 TO checks, which is wake up, warm up, tighten up, and open up. Wake up meaning a normal neurological status. Warming up means normalizing thermal regulation. Tighten up is getting down on your vasopressors, and opening up is the kidney opening up. Some of the key timings which we teach our nurses are the cross-clamp time, which they have to note, and the incision time to know the surgery. The anhepatic time when you clamp the recipient portal vein, and the liver out of ice time, the portal reperfusion, and the arterial reperfusion. The cross-clamp time to the liver out of ice time is called the cold ischemic time. It's usually recommended to keep it less than 8 hours. The liver out of ice to portal reperfusion is the warm time. The recipient portal vein occlusion to the liver out of ice is what we are using as the anhepatic time. So here I've given the calculated timing and the recommended limits. Now, this is the take-home message. DDLT today is a very standard surgical operation. There is not much technical change since the 1990s. Whatever I have talked, you can pick up from any surgical paper that is written from the 1990s. And still the standard learning paper is by Starzl and Buttshaw. That's from 1990. What has improved in DDLT is the immunosuppression has improved. Our understanding of quite a bit of physiology has improved. And in the last decade, the key change in DDLT is in the methods of organ preservation. And that's a whole different lecture. Thank you.
Thank you, Dr. Ilango. That was a very vivid and detailed presentation. It was extremely useful. I'm sure your talk with regards to the anastomosis and the challenges will be very useful for the trainees. If I may request Dr. Srinivas Reddy to switch on his camera and give his talk, then we can maybe have questions back and forth as well in the audience. Dr. Reddy? Dr. Srinivas Reddy?
Can you just give me 30 seconds?
Right, okay. In the meantime, I don't know if I may ask you a few questions, Dr. Ilango, to keep the ball rolling. I noticed that during the explant hepatectomy, you used a right hepatic vein stapler. Is that something you do only for an LDL, for all your DDLTs? Because then how would you do a 3-vein technique? Would you create a new RHV then?
So I told you, I use it only when the right hepatic vein has a vertical orientation.
Right.
In that case, I never do a 3-vein piggyback. I usually go in for a side-to-side cavectomy.
Right.
A few times when you place the clamp, the right hepatic vein in a vertical orientation tears out at the lower end. That's a dreaded thing. It's okay if you are very well prepared. If you have Alice, Judd Alice, it's very easy to control, but sometimes you end up in places where you don't get a judalis, you have to scramble and get a clamp across. It's usually a mess. So whenever I see a right hepatic vein in a vertical orientation, I just staple off. It gives me a lot of comfort.
Dr. Reddy, are we good to start your presentation?
Yeah, I'm good. Okay. Thank you. Thanks, Ashwin. Thanks to Dr. Radhakrishnan and Professor Rela for the opportunity. I think after Dr. Ilango's talk, this might be a bit of a downer, but I think he's covered quite a bit extensively, and actually there's very little that I can add except for talking probably about just the anastomosis that we do for LDLT. So I'll start off. Can you see the screen now?
And not yet, Dr. Reddy. We can see you.
Now?
Yeah, sure.
Yeah. Okay. Thank you. Thanks. So I'm going to talk about LDLT implantation, the recipient implantation. This is going to restrict myself to the adult recipient. I think the first important thing is planning. I think what we need to look at is look at all the preoperative details. Take a good look at the imaging, not just the recipient, but the donor also, so that you know what you're getting into when your recipient surgery starts. And the planning would, like I said, it's not only includes what veins you're going to anastomose during the during implantation, but also in terms of what all structures you need to prepare to anastomose. And unlike the cadaver transplantation where there's a single anastomosis, you will have to do multiple veins anastomosis in the living donor graft. Now, Dr. Ilango has extensively discussed about recipient hepatectomy, so I don't want to, there's not a lot that I can add, but I think a couple of things that we need to look at is portal vein thrombosis. The impact of portal vein thrombosis in an LDLT setting is significantly more than what it is in a DDLT setting. I think for the simple reason that the LDLT does have a narrow margin of safety, and also that we need to keep any additional vessels required if you plan to do a mesothelial jump graft, so or even a renal portal anastomosis. So the aim should be to assess the recipient's imaging preoperatively, have a good CT, look at the portal vein, look at the anatomy, and then plan before you go in, actually, rather than thinking of what to do next during the surgery itself. Very quick thing about recipient hepatectomy. I think there are for me there are 3 or 4 major areas where we can get into serious trouble during recipient hepatectomy. One is the adrenal area, which Dr. Ilango has already mentioned. So it is very common, especially when we are starting off with the recipient hepatectomy, to actually go into the wrong plane and injure the right adrenal. And right adrenal bleed is quite a challenge to control sometimes. And the technique that we normally use is take large mattress sutures just to bring the fractured adrenal gland together, so that the compression itself will stop the bleeding. If taking fine stitches or argon or diathermy usually will not help in adrenal injury. I think what we need to do is take a large suture, usually a 4-row stitch over and over around the adrenal gland, so that it gets compressed and the bleeding stops. The other common area of injury is the tear at the gallbladder when we're doing the recipient cholecystectomy. Not cholecystectomy, when we're dealing with the Callet's triangle, and there any little extra retraction by the assistant can actually tear the gallbladder off the liver surface, and that can actually cause quite extensive bleeding. So that's something that we need to be very careful of. And probably some of the maximum bleeding that can be encountered is when there's a splenic injury, when we are trying to divide the left triangular ligament, and if the ligament is, if the left lobe is adherent to the spleen, a capsular tear on the spleen can cause significant bleeding, especially when you clamp the portal vein during implantation. So that's something that you need to be very careful of. And if in fact, Professor Hill always says that if your spleen is really adherent to the liver, then probably better to leave it to the end when after your devascularize the liver, and actually you can leave a little bit of the liver capsule and liver parenchyma on the spleen rather than risk tearing the splenic capsule. In terms of the LDLT recipient, I think the hilar dissection is slightly more higher as compared to the DDLT recipient. So we want multiple branches of the artery of the bile duct, as corresponding structures in the graft are going to be smaller and shorter. So we definitely will take the left and the segment 4 arteries separately. If possible, we would like to take the right anterior, right posterior arteries also separately, but at least the right artery to the right of the bile duct is what we should aim for. Now, we as a routine, we normally divide these arteries. We tie and ligate and divide the arteries. We also use a bulldog clamp, especially on the right artery, before we tie it, so that the artery doesn't crush against the high flow in the artery. That to decrease the risk of dissection. But there are some centers who don't really tie the arteries; they just put strong bulldogs and then cut the arteries high up to minimize the risk of dissection. So, so that's another technique of doing it. I think the key in hilar dissection is to remember that arteries can dissect easily, especially as you go more distally. Veins, canavals, there can be veins on the cava, there can be veins around the portal vein, which can avulse, and then they can cause bleeding. And an avulsed vein is much more difficult to control than a cut vein, because it actually tears a part of the wall of the main cava or the portal vein. So your hole in the vein is going to be, in the main vein is going to be much bigger that you need to repair. And bile ducts, the aim should be to not to skin the bile ducts, as you know, the blood supply to the bile duct comes from the outside. So you need to have a good amount of tissue around the bile duct so that they don't get devascularized. A retrohepatic dissection, I think Dr. Ilango again has gone quite extensively in this. I think just a couple of points. What technique you use to control these veins, either the caudate veins or the inferior right hepatic veins, depends on the size. So smaller veins you can tie. We usually tie and put a stitch also. But a larger vein, it's better to actually put a spoon clamp and suture it, divide and suture it, rather than tying it, because the tie can very easily slip from these larger veins because the base is quite broad. Another thing that we need to remember is when we are, if your graft is going to have an inferior right hepatic vein, you need to keep in mind that you shouldn't really use any liga clips in the lower part of the cava, because first of all, they can come in the clamp, and that means the bite will not be secure. And secondly, if you put a clip and then you put a clamp, and when you release the clamp, any clip that gets dislodged will cause bleeding. So you need to tailor how you deal with these veins based on the size of these veins and the position of the veins and what venous reconstruction you're planning to do in your partial graft. Now, the temporary portal caval shunt. I think temporary portal caval shunt can be a lifesaver in actually in a significant number of cases, especially when we're starting off to do transplants. It's definitely useful in acute liver failure where there's no actual portal hypertension and there's no collaterals. So prolonged clamping can cause significant bowel edema. So if you do a shunt, you are much more safer. It is a very useful procedure to use when you are transplanting a non-cirrhotic metabolic liver disease patient like oxalosis or clitonasia, because once again, it's a non-cirrhotic, so there's no portal hypertension, no collaterals. Any portal clamping for more than 15 to 20 minutes will cause significant bowel congestion. So shunt will help decompress the mesenteric circulation while you are doing the rest of the operation. Definitely in case of patients who have severe portal hypertension, who are quite sick, and who have a difficult hepatectomy because of a large caudate lobe, a portocaval shunt will help in decreasing bowel congestion, reducing portal hypertension. The liver becomes much smaller, softer, easier to rotate, and it's much more, you can actually deal with the caudate veins and the inferior right hepatic veins in a much more safe way, as long as your shunt is on. The main concern in the LDLT setting is obviously that your portal vein will get shortened, and that you might have a problem with the implantation. So as a rule, when we're doing a shunt in the LDLT setting, what we do is we tie off the left portal vein and we use the right portal vein for the shunt. If the length is still insufficient, then we sometimes use an interposition graft, an 8mm PTFE. Portocaval shunt is also useful when we have a graft with two portal veins, in which case we as a practice, we use the portal bifurcation of the recipient liver to reconstruct the two portal veins. So in that case, we have to take the Y segment of the portal vein for reconstruction. And we would usually use 8mm PTFE to bridge the gap between the recipient residual portal vein and the cava while the shunt is, while the back table is being done. This is a cartoon from Professor Lee's paper 2015. I think it's probably one of the most commonly used pictures to highlight the various aspects of successful implantation. I think the key for us is to have good outflow of the hepatic parenchyma, portal flow which is sufficient but not too much, secured hepatic artery anastomosis, and bile duct anastomosis. So there are many ways of doing it. The good thing, or maybe the not so good thing about living donor liver transplantation, is that every unit has its own way of doing things, its own way of hepatic venous anastomosis, outflow reconstruction, arterial reconstruction, bile duct anastomosis. So there is no one right way. There's no wrong way. If it works for a unit, it works for a unit. I will be talking here about the technique that we all learned with Professor Rela. So this is the technique. The technique that I'll be showing you will be what we use in Dr. Rela's unit. So first is venous reconstruction. So preparing the cava. We always use a cava preserving hepatectomy. We divide the right hepatic vein and the middle and left hepatic vein complex separately. Use separate clamps. And once the liver is out and the hemostasis is secured and we're happy with everything, then we prepare the veins. So the right hepatic vein is usually, we excise the hepatic vein segment so that the graft is implanted directly onto the cava rather than onto the right hepatic vein stump. This make sure that there is no excess length of the right hepatic vein to kink or to twist after the reperfusion. The middle and left is again clamped in a single clamp, and depending on what kind of anterior sector reconstruction we're doing, we'll have to deal with that in that way. So if there's no anterior sector reconstruction, we suture it off. If there is a PTFE graft, then we close the orifice to the extent of the size of the PTFE graft that we use. So if it's an 8mm graft, we usually close either the left or the middle hepatic vein. If it's a 10mm graft, then we will probably use the common stump as the site for implantation. In terms of the middle hepatic vein reconstruction, we use a PTFE graft. It's single reconstruction, segment 5 reconstruction. If it's 5 and 8, then we prefer to use an cadaveric iliac vein graft. But I think more and more, especially now with reduction in the number of deceased donors, there is a shortage of these veins, and more and more we're using a PTFE graft for both segment 5 and 8 reconstructions. Inferior right hepatic vein reconstruction, any vein which is more than 5mm, we do reconstruct, and there are some centers who use various techniques to see what is the significance of these veins before they decide on reconstruction. But anything significant, we usually retrieve them with a a small cuff of the cava so that you can take good bites. And it's a simple straightforward anastomosis onto the side of the cava while the cava is clamped with side biting clamp. Now, if there are multiple inferior right hepatic vein anastomosis, then if they are far away, then we have used 2 separate IRHU anastomosis. But if they're close by, then we do a plasty with the cadaveric vein patch to get a single outflow for the inferior right hepatic vein. Now, we have as a unit, we have always used multiple outflows. So we have a separate outflow for the right hepatic vein and a separate outflow for the anterior sector. We don't use a single outflow technique. But there are now many centers which actually use a single outflow technique, where most of the reconstruction is done on the back table, and then you have a single in anastomosis to do during implantation itself. So there's been a recent publication by the ILBS team where they've talked about comparing multiple outflows with a single outflow, as shown in the right picture, and they've shown better results with single outflow. But there's always a problem in comparing two things from different eras. With the increasing experience of the team, there are many other things that you don't actually account for when you are comparing two techniques. There's another technique by Thorat et al. Published way back in 2015. This is also the technique used in many centers in Turkey, where everything, including the inferior right hepatic veins, are put onto a single outflow, and then you do an anastomosis like you do in a in terms of the portal vein anastomosis, I think the basic principles are similar to what it is in a DDLT. There are a few issues. One obviously is that the graft portal vein is much shorter, so it's always a little bit tricky to know your orientation on the graft side. There are a few tricks. One is to look at your septum, separating the right anterior and right portal vein, and the corner stitches should usually be around on either end of the septum rather than at right angles to the septum. This is for a right lobe graft. Another good guide is the side of the portal vein, which is slightly more thinned out, because during donor surgery, when you try going around the right portal vein, there is a little bit of thinning of the medial aspect of the right portal vein. So that should give you a guide in terms of placing your corner stitch. In the LDLT setting, I think a slight rotation can cause significant problems, because that twists the outflow, which is immediately dividing into the anterior and posterior segments within the liver. So you need to be much more careful and much more careful about getting the alignment right and the rotation right, so that there is no twist in the portal vein anastomosis at the end. We always use a growth factor to make sure that there's enough room on the suture line for it to expand as the portal flow increases once we reperfuse. So we do leave a generous growth factor for the anastomosis to increase in size after reperfusion. Two portal veins are not uncommon. Probably about 15 to 20% of all right lobe grafts will have a double portal veins. There are many techniques. What we used to use before was a Y-graft technique, in which we take the Y-graft from the recipient portal vein and use that for the anastomosis. More recently, we started using the conjoint venoplasty technique, where we put a patch between the two veins and then use the funnel of the portal vein bifurcation from the recipient to do a circumferential suture. This minimizes the chance of a twist in one of the portal vein anastomosis, and we've had good results with that. Though when the two veins are too far apart on the graft, I think still a Y graft might be a better option to use than a conjoint venoplasty. Arterial anastomosis, I just wanted to show the technique that's used in Dr. Ila's unit that we've all learned. So it's a back wall supported technique, where we take two stitches at the back and then we go come on either side circumferentially till we get to the corners, and we do the anterior layer. Now, the advantage of this, especially in the LDLT setting, is that if your graft artery is short, turning it can increase the risk of shear injury for the artery. So this is a much more safer way of doing the anastomosis because there's no turning involved of the graft artery. But having said that, there are many centers which do it the flipping way. So it's what you are used to and what you're trained to do. Multiple arteries are again not uncommon in the LDLT graft, and we do see them in again maybe 15 to 20% of all grafts, living donor grafts. What we use a selective arterial reconstruction policy. So if there is there's one big artery and a smaller artery, then what we normally do is we cut the smaller artery first in the donor surgery. And look for pulsatile back bleed while clamping the portal vein. If there is pulsatile back bleed through the smaller artery, then I think we can be reasonably sure that there's good collateralization at the hilar plate level, and we can safely get away with doing a single anastomosis. Whereas if there are two arteries are of similar size, or if the back bleed is not pulsatile or not very good, then we do a double artery reconstruction, which can be with a backtable Y graft taken from the recipient artery itself, or occasionally when we decide to reconstruct the second artery during the recipient operation itself, then we can use another arterial branch from the recipient to do the anastomosis. But there is no clear evidence to suggest that two artery reconstruction is superior to single artery reconstruction. There has been some literature showing that biliary complications are more when we do a single artery, especially in the left lobe. I think this would this might be because in a left lobe graft, when you leave the bile duct long in the graft and it's supplied primarily by segment 4 artery branches, then reconstructing just the segment 2 and 3 might cause some amount of biliary ischemia. That's just a theory. But there are a couple of studies which have said that, especially in left lobe grafts, if you reconstruct only the segment 2-3 artery, then there is an increased risk of bile duct strictures. But there is no universal consensus on that. So as far as we are concerned, if there's good back bleed, pulsatile back bleed, we are happy with just reconstructing one artery. I thought I'll just talk briefly about a dissected artery. Dissected artery can be a major issue in during surgery, especially in the LDLT setting, because it's not easy. We would not always have good quality iliac results to do aortic conduit. And this is one technique that, again, Professor Ella has used, and we've used it quite often, which helps in dealing with this situation. So the theory here is that dissection always progresses proximally towards the common hepatic artery, and gastroduodenal artery is usually spared of the dissection because there is forward flow from the pancreaduodenal arcade. So what we do is we divide the GDA at the junction of its junction of the CH with the common hepatic artery, and we have used this as a arterial inflow. These are some pictures that Dr. Ramkiran has drawn for the manuscript that we've actually submitted now, to show how the dissection progresses and spares the GDA. And we've had good results with this, and you can see the reconstructed CT image of the artery showing good blood flow being fed from the SMA through the pancreaduodenal arcade. So this is a good way of salvaging a situation when your common hepatic artery is dissected. We've used this as the most common rescue strategy in our unit. Coming to the bile ducts, again, multiple ducts are very common in LDLT, especially in right lobe donation, and we've used a lot of techniques to deal with them. The ducts are close by, then we can do a plasty, or we can just do a circumferential anastomosis to the hilar plate tissue around the bile duct. If the ducts are far away, then you can use the left and the right hepatic ducts of the recipient to do two anastomosis. When that is not an option, then we've used an end-to-side anastomosis for the more anterior duct, and the duct-to-duct end-to-end anastomosis for the more posterior duct. And if none of this works, then obviously we do have the option of a roux and anastomosis. There has been some literature to say that if there are multiple ducts, then doing a roux and Y or a combined technique such as one duct to duct and one roux and Y has better results than two ductal anastomosis. But we've, as a practice, we've always tried to use ductal anastomosis if at all feasible, and use roux and Y anastomosis only when ductal anastomosis is not feasible. The principles of bileduct anastomosis are the same. Avoid tension. We take the hilar plate tissue in the bite so that they give good purchase for the sutures. Usually interrupted sutures using 7/0 PDS, and we should check for caudate duct leaks on the graft by flushing the posterior duct and on the recipient duct, especially when you're using your right and left ducts of the recipient to do two anastomosis. You need to make sure that there are no caudate ducts which are there in between these two ducts which are open, and it's important to flush and check and suture them carefully before we proceed with doing the anastomosis. So that's it with the reconstruction. I've not dealt too much about left lobe implantation because it can also be covered in the pediatric implantation. Briefly about graft size. Now, way back in 1999, Keishu et al. Reported their data from 276 living donor grafts, and they showed that as the size of the graft became smaller, survival decreased. So they called a graft size of less than 0.8 GRWR as an extra small graft, and they showed that the outcomes are much worse as compared to grafts which have a GRWR of between 0.8 and 1 or even more than 0.1. Now this was what they reported was a syndrome of postoperative cholestasis, coagulopathy, prolonged drain output associated with the small grafts, and it was called a small for size syndrome. Thanks to Professor Clavian's definition, a 0.8 GRWR was used as a cutoff to define a small for size syndrome. Now, what is the pathophysiology of small for size syndrome and small GRWR graft? I think there are two main things here. One thing to remember is that the amount of portal flow in a cirrhotic is much more than what it is in a normal person. So you can have a portal flow of almost 2 to 3 times the normal portal flow, because cirrhotics have a hyperdynamic circulation. They have a large spleen with a large splenic vein inflow into the portal vein. So a cadaveric whole graft can still manage this high portal flow. But when you use a partial graft, it can cause significant sinusoidal shear injury. So the high portal flow can actually injure the sinusoidal endothelial cells, which leads to release of a lot of inflammatory mediators, leading to a sort of an SIRS-like syndrome. Now, little excess of sinusoidal shear injury is actually good because it stimulates liver regeneration, but when it's excessive, it can cause significant injury. The second problem is that when you have a high portal inflow into the graft, the automatic there's an automatic reduction in the arterial flow because of the portal arterial response. So as your portal flow increases, the artery flow decreases, and this causes relative arterial ischemia to the graft. So you have a situation where your portal flow is very high. It's actually damaging your sinusoids, and then the arterial flow has come down, and we know that the hepatic artery is the main source of oxygenation for the graft. So there's an amount of ischemia that's caused because of this reduction in arterial flow. So these two factors lead to graft injury. The second thing is that there is a difference in the rate at which liver regenerates. The liver regeneration is the basis of living donor liver transplantation. So we expect that the graft, the partial graft, grows into a to a near full size graft volume over a period of time, and thus supports the patient's metabolic demands. But the rate at which various components of the liver regenerate, grow is different. So your hepatocytes grow much faster, or regenerate much faster, multiply much faster as compared to the supporting cells, such as the sinusoidal endothelial cells, or your Kupffer cells, or ductal epithelial cells. So when there is excessive portal shear stress stimulating excessive regeneration, there is a far faster growth of hepatocytes, leading to congestion within the liver, pressure for metabolite, for nutrients and oxygen, and which actually further drives the injury that causes that leads to small size syndrome. So what should we do to deal with a low GRWR graft? Obviously, the best thing would be to have a higher GRWR, but if that's not an option, then there are a few strategies. First thing is to increase your graft functional volume. So if you're thinking that your GRWR is less than 0.8, it's 0.7 or 0.6, then is there any way we can actually improve the outflow for the liver? Because any congested part of the graft is effectively not functional. So you would like to make sure that the entire graft is fully decompressed, has a good venous outflow. Can we take a partial middle hepatic vein from in the donor, as opposed to just segment 5 and 8 veins, to improve your drainage? Is it possible to take the whole middle hepatic vein of the donor? If the donor is a young, fit person and your remnant is good, it's like 35%, 40%, then can we take the full middle hepatic vein so that the entire anterior sector is fully drained? Are there any inferior right hepatic veins that we should reconstruct to improve the drainage of the posterior segments? So these are all things that we need to plan before the surgery itself, so that there are no surprises during the operation. Because normally your graft volume might be slightly lesser than what is calculated on the CT. That's because your graft on the back table doesn't have any blood in it, so the weight is lesser. But you need to be prepared. So if your GRWR is on CT is coming to 0.7, then you should be prepared for a 0.65 GRWR and plan accordingly. The second thing is that is becoming more and more important these days, as we try to improve donor safety by taking smaller grafts, left lobe grafts, is the role of portal flow modulation to optimize portal and arterial inflow to the graft. So the aim of portal flow modulation is to keep the portal flow to a safe level, so that it is sufficient to stimulate regeneration, but not excessive and cause graft injury. Now, studies by Trolzi et al. Have shown that the normal portal flow in a normal liver is around 90 ml per 100 grams per second. Per second, I think, yeah. Per second, I think, yeah. So, and they reported that if it's more than 3 times this, so if it's more than 250 ml per 100 grams, then it's a problem. The graft injury sets in. So your aim should be to have your portal flow between these two limits. It should be more than 90 so that your graft regeneration is stimulated, but it should not be more than 250 to avoid graft injury. And once we reduce graft portal inflow, the arterial flow will automatically increase, because it's a reciprocal response. And techniques like splenic artery ligation can actually improve this further by diverting more of the celiac artery blood flow into the liver, at the same time reducing the splenic venous inflow into the liver. So you have the combined effect of improved arterial flow and reduced portal flow. More aggressive techniques, such as a partial portocaval shunt, is used when the graft volume is very small and your portal pressures are high. Again, there is still no uniform consensus about the relative importance of portal pressure and portal flow volume and graft outcomes. But we've always used portal pressure as a guide to manage portal flow, because that is a reproducible and quite accurately measured metric as compared to portal volume, which is a calculated metric using ultrasound Doppler, unless we have the flow probe. So we used a portal pressure of 15 as a cutoff, and we use portal flow modulation techniques if your portal pressure is more than 15. So I think I'm missing a slide. Anyway, so a living donor transplantation graft, it is a sort of a tightrope walk. You need to be careful, have good planning before you start the operation, and keep reassessing the situation intermittently. The aim is to have a well-drained graft with optimal portal inflow and good arterial inflow, and a safe bile duct anastomosis, so that technical complications are minimized and patient has a good outcome. Thank you.
Thank you, Dr. Reddy, for the excellent talk. Again, very vivid, and it's good that you covered the physiology. To start off on a slightly lighter note, are you Calvin or are you Hobbes?
I am Calvin, the naughty one.
All right, as always. I can see Prof is in the audience. Prof, are you there? If you could just join us for a few questions. Dr. Pari as well, if you can switch on your Prof.
Yeah, hi.
Hello, Prof. Thank you for joining us. It's already an hour and a half. We won't take too long. If you would like to add some pearls to a safe hepatectomy, is there something which you would like to add to what Dr. Ilango has already?
No, I think Dr. Ilango did a very good job, actually. I hadn't heard a talk on, disease donor transplant like that. It was very well structured and very good. In fact, I learned a lot of things. If not technique, I think I learned how to present this very well, actually. I think it was very well structured. I liked it very much.
Right. If I may also ask Dr. Pari to join in. Now, I would like to start by asking, now with the excellent, hello, Dr. Pari, thank you for joining in. Now, with the explant hepatectomy, you do have these newer energy devices, LigaSure, Thunderbeat. Has anybody used these? I mean, does it make it easier? Is it for, more safer hepatectomy? Does it enable that? Dr. Ilango, Dr. Reddy, Dr. Pari, if you can take it in turns, then I would like Prof's opinion as well.
Ilango?
The only time I have used a LigaSure in my for open surgeries when I did a Whipple on a post liver transplantation. That was the only time. I'm really uncomfortable with energy devices, and I don't recommend any of the harmonic devices in a liver transplantation. It invariably causes lots of bleeding. I prefer the simple, plain old techniques of TICE and the electrocautery. That's just my choice.
Right. Dr. Pari?
Yeah. So I'm going to say that during my fellowship days, it was pure cautery only, monopolar cautery. And then once back in India, I learned from Professor Surendran using harmonic for dissection of the triangular ligaments and most of the other stuff, even in the porta. And I picked it up from him, and I tend to use more of harmonic for the triangular ligaments, and seems to be working well, less bleeding probably, and I'm sure that everybody uses they have their own technique, and for me it looks like the harmonic also is equally good.
Right. Dr. Reddy, and you were slightly partial to a ligosure, so I would like your opinion on that.
I've not used it, but I think a lot of centers use it and they're happy with it. I think it is something that will probably become more and more used as people become comfortable using it. I think you need to get used to using it. Until that, need to be careful. But I mean, if it works for everybody, for others, then it should work for everybody.
Yeah. Prof, your opinion, especially since you're doing a fair amount of robotic with harmonic, do you feel we should use it in open recipient hepatectomy as well?
No, I mean, I don't think it's necessary to use it. I mean, done thousands and thousands without these energy devices. I still find it comfortable to operate with conventional things. But I think in the future, if people are moving towards robotic, I think it may be a good idea to just try it on open before moving, or they can simply actually start like what we have done, do it when we need to do it. But I think the energy devices are a good idea, I think, and the blood loss will be reduced. I think overall, they are going to make the operation more straightforward. I think I'm somebody who's quite keen for people to adapt to newer technology. I'm not saying go and do all your transplants with harmonic, but I think to keep that also available is not a bad idea at all. But I've not been using it, having said all of that. But I'm sure they're going to have an increasing role in the future.
Right. Thank you, Prof. The other question which I was wondering when Dr. Ilango was talking about the blood flush, we use a room temperature saline flush as compared to albumin versus a blood flush. Is there any difference? I mean, what is your routine protocol? Have you changed it in India? Dr. Ilango, Dr. Pari, and Dr. Reddy can take it.
So I still use the cold saline flush. The only thing I have made difference, and that's after watching Prof, is to do it in situ. And that too only when I started working with Pari. We became very comfortable with putting the liver in, completing half of the portal vein anastomosis, and then using a saline flush. But still, despite all that, I still use a blood flush too. That's probably more out of habit rather than any big benefit.
What do you feel is the advantage of a blood flush over a saline flush for the juniors in the forum?
I think we are more, one is the anastomosis opens up, problems in the portal vein anastomosis much more earlier. That's a simple one. The second one is that at least a good amount of flush must have been done on the back table, which probably reduces the reperfusion syndrome. I have made that mistake a couple of times, depending on others, to do the saline flush and skipping the blood flush altogether, and then ended up pretty bad with a near cardiac arrest situation. So I do this probably out of habit, but I don't think so I have any benefit out of it.
Ilango, how much of a blood flush do you do? How much do you discard?
Prof,
how controllable is it is another thing. I find it difficult to exactly control how much is lost actually.
Yeah, I agree with that. What we do is the venting side is really small, and I have a stitch placed there so that I can lift up and actually see the place. And once a few, 100 ml of blood comes out, I usually clamp the portal vein. The rest usually flows out gently. I don't have any recommended one, but I usually see how the liver color changes. That's as much as I do. There is no actual volume. This was taught by Dr. Chris B. Hughes, and I have not changed it because that's probably the only technique I learned in liver transplantation from my training days.
Dr. Pari, and would you do something different?
No, same. We do both cold flush with cold saline or 5% dextrose, and also blood flush. We don't know, but the cold flush is supposed to flush off all the HTK or the University of Wisconsin solution. And the blood flush we give, thinking that, the stagnated blood from the mesenteric system, you don't know whether it's whatever high potassium or other toxic substances, we think that we are going to let it off. As far as the amount concerned, there's no hard and fast. We tend to leave it for a few seconds, say 100 200 ml of blood. Once it comes out, then we tend to clamp the portal in again. And one thing which we changed over time was we almost completely gone on to side cavostomy, and we went it from the suprahepatic cava, rather than the infrahepatic cava, because many times the portal vein comes in front of the infrahepatic cava, and it's difficult to suture it, or if there is a bleed. So we tend to close up the infrahepatic cava, and blood went through the suprahepatic cava, which is partially closed. We feel it's easier to close it off.
That's an extremely useful suggestion.
Prof,
Dr. Reddy,
Prof, is there a volume? Can I ask a question to Prof?
Yeah, sure, please.
Prof, is there a volume that we should specifically use for the saline flush?
Oh, for the saline flush. For saline flush, I actually use at room temperature. I'm very particular about that. And for a whole liver, I would use 1 liter. For a partial liver, maybe at least half a liter. The reason I use a room temperature saline is, see, when you're doing an anastomosis, you put the liver on the abdominal cavity and do the anastomosis. If you say on an average, it takes about 45 minutes, and and at worst actually, if it takes an hour, the liver is rewarming, and the rewarming liver warms along the surface of the liver. The core of the liver wouldn't rewarm quickly. So the idea of really the saline flush at room temperature is also to rewarm the liver at the core part of the liver. So when you're reperfusing it, all the vessels are completely open and they're not spastic. The cold is not causing the microvasculature to be completely spastic. So it'll really perfuse uniformly. I mean, also one of the purposes is to wash off all the preservative solutions and all of that. And apart from that, I think it's also useful to open up all the microcirculation. Your blood warming does that extremely well, because the blood flush also does exactly the same. The blood flush opens up everything. I asked you that question because about the volume to flush. One of our fellows wrote a nice article about the difference between blood flush, and this is many years ago, 20 years ago. We found nothing really. There was absolutely no difference between blood flush and saline flush in terms of reperfusion injury or early graft function or anything like that. So in the early days, I used to flush about 200 ml is what I thought should be the correct amount, and we used to do 200 ml flush. But I always discovered, so you allow 200 ml and then you clamp everything, you land up with almost 500 ml of blood coming out when you actually measure it. So it's so difficult. And maybe your idea, I never thought about that, your idea of letting go 100 ml and then clamping the portal vein and then letting go of the rest of the blood, I didn't have. But I found Pari's explanation interesting. For the first time, I've heard that the blood flush is also useful for letting out the stagnated blood from the mesenteric system. And it's useful. I mean, if you felt that stagnated blood is not good for the system, it's neither is it good to go through the liver. In that case, you should actually let go of the stagnated blood through the portal anastomosis and then only go through the liver, if you understand what I mean. But stagnated blood is never a stagnated blood, really. I mean, there is so much portosystemic collaterals that even though there is some element of congestion and stagnation within the mesenteric system, it's completely not stagnant for the half an hour or 45 minutes that you're clamping it. I don't think that makes a huge difference, but I found that that's an interesting thought process as well.
Thank you. And talking about collateral ligations, Dr. Ilango, I saw in one of your slides, you were talking about collateral ligations in adhesion. How often do we actually do that?
Only when the flow is, am I audible? Yeah.
Yeah, you are audible.
Only when the portal flow is inadequate. I still use the criteria of 20 centimeters per second PSV. If it is very low, I go ahead and ligate the collaterals. And we usually have the habit, I learned it from Pari, so we map out all the large collaterals more than 10 millimeters on the preoperative CT scan. So I know exactly where to go and ligate. I usually clamp them first, make sure it goes up on the Doppler, and then ligate it. I just don't go and blindly ligate. I usually test clamp them before I ligate. But anything more than 10 millimeters in size, I tend to do this, especially when the portal flow is inadequate.
And Dr. Reddy, and what's your opinion? What's all the fuss about is your article, isn't it?
I think collateral ligation is useful when your portal flow is less and there is shunting of blood flow. I think it's probably more relevant for the LDLT graft, not for the cadaveric graft. I think one thing that we need to remember that I realized recently was that if you're going to do, if your portal flow is less, and you're thinking of collateral, we need to find out why the portal flow is less. So if it's a small portal vein or a thrombectomized portal vein and your thrombectomy is not complete and there's still a partial obstruction, ligating collaterals is not going to improve your portal flow. What it will do is it will actually increase the congestion, and it's something that we had a case recently where we did a thrombectomy, flow was adequate, and to improve the flow further, we clamped the renal vein. It looked okay, so we tied it, and then after 10 minutes, the bowel was getting congested because there's not sufficient inflow through the portal vein into the liver, and the big collateral which is draining into the renal vein has been clamped now. So I think we need to know why the portal flow is not sufficient, and see if we can actually correct that bit before we ligate collaterals to direct the flow into the liver. I think that's something that we should remember.
Yeah, we check the outflow. That protocol is slightly different. So we check the outflow, make sure the outflow is good before we do all this.
Prof,
I agree with the.
Yeah. What is your opinion? I mean, how often did you do a collateral ligation back in King's as compared to doing it here?
Yeah, I think, I mean, that's why we wrote the paper. What is the fuss about? The relevance is less in the diseased donor, unless there is, as Ilango said, a reduction in the flow into the liver. It's not, actually I only found one paper on collateral ligation by John Roberts, if I remember right, when we wrote that paper. But in the living donor, I think it is very relevant. You just have to think of it as an increased resistance to the graft from whatever reason, either at the time of the operation or immediately after the operation. I think the likelihood of the portal flow reducing or the resistance to the portal flow increasing in the subsequent days, in the first week of transplant, is much more than during the operation. You might think it's okay during the operation. So when the graft becomes stiff, if there is a big collateral, the shunt will actually take the blood flow away from the liver into the shunt. So you're actually ligating the collateral and forcing blood, even if it has to be a higher pressure. You're forcing blood through the liver, and that is required in a segmental graft rather than for a whole liver. And for a whole liver, the capacity or the venous flow is so much more through the liver. It's unlikely that it will develop that sort of resistance to shunt blood away from the liver, and that's why it's more relevant in the living donor. But having said that, you find at the time of the operation, there is an increased resistance to the liver without any problem with the outflow. In fact, Ilango said we check the outflow. It is important to check the outflow to make sure that that is not the cause for the slow flow. But if you happen to have a small degree of outflow, it's even more important to actually ligate the collateral. Otherwise, you will not direct, the outflow is actually going to prevent flow through the liver. So even in those situations, actually like collateral ligation might potentially help rather than harm the liver. Unless the liver gets congested and the portal pressure goes very high. If the portal pressure goes very high because of an outflow problem, that needs to be corrected for sure.
Right, Prof. Thank you. There's a question in the chat window about interrupted versus continuous arterial anastomotic technique. Dr. Ilango, what's your experience? Dr. Pari as well?
In small arteries around 3 to 4 millimeters, I think interrupted technique is good. But apart from that, the larger one and in the branch patch anastomosis, especially when you're training, I think a continuous technique works equally well. For those of us who are trained in microvascular surgery, it is still possible to do a good continuous anastomosis even with very small vessels. We're doing this regularly in AV fistula. It is just your own variation, how comfortable you are with. I don't think so there is any advantage you get out of a continuous versus an interrupted one. I really admire the way Srinivas Reddy does his arterial anastomosis, because the original interrupted technique I learned was from Professor Rayla's paper written in King's on the partial liver graft arterial anastomotic technique, the trifurcation. But then after seeing him, I changed the technique to what he was describing here. So that's a much more easier technique.
And Dr. Pari, what is this arterial check of Ajita with Ilango referred to earlier?
Oh, that's nothing actually. So what we do is while doing the the cholecystectomy after the artery is over, we always tend to check the cystic artery blood flow. So we don't ligate the cystic artery. We tend to cut it, and if we see a pulsatile blood flow from the cystic artery, we feel happy that arterial flow is good. So we used to just we kept a name that it was a sign of Ajita. Ajita was my colleague back in those days. So we always tend to see the cystic artery blood flow just to make ourselves feel good about the the arterial flow. So we labeled as sign of Ajita.
Prof, yeah, sorry, Dr. Pari, I interrupted you. Go on.
No problem. If I can go back to the collateral ligation, I think one of the things that we tend to see is the anatomy in the preoperative period, even in DDLTs, if there is a very big shunting, and especially if there is a big shunt going to a left renal vein and hepatofugal flow, we always tend to try and loop the left renal vein, because these are the patients where there is a higher chance of big shunts causing poor flow in the portal vein in the post-op period and portal vein thrombosis. In these cases, we keep the left renal vein looped and ready. If you're not happy with the portal flow, we tend to ligate the left renal vein rather than dig around and try to get into the collaterals. Nowadays, we directly go and loop the left renal vein, keep it ready.
Prof, if I may take you back in time, why did you, choose this type of an arterial anastomosis which you do? Is this what you learned, or is this what you came up with?
No, I think that's what we learned, and we were doing a lot of pediatrics right from the beginning, and I thought if the artery was to grow, it's better not to have a continuous anastomosis. But large arteries, we always did continuous anyway. When we do in the cadaver operation, celiac to celiac or branch patch, it was not uncommon for us to do. But after starting splits and things like that, and we did this triangulating technique where we had the posterior as two limbs for the triangle. I don't know if you read the original paper. So you could actually, you put the two stitches, one on this side. I now don't actually do it exactly as it was described those days. So the triangle will consist of one at around 5 o'clock and another one at about 8 o'clock, or 4 o'clock and 8 o'clock. And the 12 o'clock, there are two corners in the 12 o'clock and not one. One on the right side and one on the left side. And you hold each of these triangles. It just prevents catching the other side wall, and it's easier to do. So you do one side, the left side first, the right side, and then the anterior wall after flushing it. It's safe to do is how we described it. I mean, this is very early days of transplantation. I think people can now adapt. People who do microvascular surgery can do whichever way they want. But the thing about continuous, I've always found, if you do a continuous stitch and you do an angiogram and look at it, there is like a stricture if you do angiograms in patients where you've done a continuous stitch. We tend not to do growth factors for arterial anastomosis. You do a growth factor for portal vein and hepatic vein anastomosis. People tend not to do because it bleeds as soon as you've left a growth factor. I still think there will be an element of purse string effect, even in microvascular and very small anastomosis. If you do a continuous in let's say a very small artery, you do a continuous, you want to leave something like a growth factor, there is a danger that this growth factor could actually form a small loop inside the lumen. And if a small loop forms inside the lumen, that can form the site for really a little thrombus to form. And even the smallest of the thrombus in a microvascular anastomosis will occlude the lumen. The third point I would like to say when you do microvascular anastomosis is, I mean, this is so when you do rat work, this is something that I've found when I used to do rat work. When you complete the anastomosis, your suture line cannot bleed. When you do a very small, say 2 millimeter artery, and when you complete the anastomosis, you cannot have bleeding from the suture line. The general tendency is you have a slight bleeding from the suture line, you just put a swab on it, and then it will stop bleeding and everything is going to be okay. But that's not okay for microvascular anastomosis arterially, because when you have a small bleeding point at the suture line, it's usually closed by a platelet plug and then only stops. And this platelet plug, if you actually cut that anastomosis and see, is within the lumen itself. And in very, very small arteries, if you get platelet plugs within the lumen, there is a risk of thrombosis of these very, very tiny vessels. So microvascular anastomosis always has to be a perfect anastomosis with no oozing or bleeding from the suture line, which stops subsequently. So that's, I always felt that. I actually learned this from a lady who taught me in the microvascular course in, I don't know how many of you that have been in the UK and trained in microvascular surgery. There is a place, what is that, in London, where they run a microvascular course. And there is a lady who teaches microvascular surgery. And she always told me, if you do a microvascular anastomosis, you cannot have suture line bleeding.
That's the Northwick Park Hospital.
Yeah, Northwick Park, that's right. Northwick Park. That's been running for the last 30 years, I think.
Yeah.
The other question which I would start with Dr. Reddy is with regards to reperfusion. When would you do an arterial reperfusion as compared to a portal reperfusion, or when would you do a simultaneous reperfusion? And I would also like to know Prof's views, because he has an old paper from about 30 years ago with regards to that. Dr. Reddy.
I've never done a simultaneous reperfusion, but I think arterial reperfusion is good if you're not very sure about your portal flow. So a couple of times when you've done a thrombectomy and not sure of the portal flow, then we do a portal arterial anastomosis first, so the liver is not ischemic while you sort out the portal way. I think that at least prevents continued warm ischemia of the graft. But I've never done a simultaneous reperfusion.
And is there any advantage with regards to biliary complications? Have you any experience with that?
I think there's some studies which have reported that if you do simultaneous reperfusion, outcomes are better. But then again, there's a selection bias there. Obviously, centers which have the better results will be reporting those things. And if somebody is doing simultaneous reperfusion consistently, then obviously they are at a more experienced stage than somebody who just starts off with doing simultaneous reperfusion. So I don't know. Maybe it is it improves biliary strictures because it improves biliary vascularity. But it's not something that I've done or neither have I seen.
Okay. Dr. Pari, you would like to say something? Yes.
Yeah, I guess a couple of times when we are expecting a very bad reperfusion because of prolonged cold ischemia time or a fatty liver, we have had instances where we wanted a slower reperfusion. So we have reperfused with the artery first and then the portal vein, but there's been very few. So we would reperfuse with the artery first when we are expecting a really stormy reperfusion because of cold time, a prolonged cold time, and a very steatotic graft.
Is it more common to do that in a DCD liver?
I'm not sure. DCD, and no experience with the DCD livers, more with DCD kidneys only. We've done it with DBD livers with prolonged cold times and a steatotic graft. Maybe DCD. I'm not sure.
Can I ask Pari a question? See, you're saying hello.
Yes. You're audible.
Dr. Pari, so you're saying that if you're worried about rapid reperfusion with portal, then you do an arterial reperfusion. But I mean, you can always do a portal reperfusion and do it and reperfuse slowly. Even in an LDLT setting, we reperfuse over 1 to 2 minutes, and you can partially clamp the portal vein if you don't want to reperfuse quickly. I mean, technically speaking, it will take longer to do an artery first reperfusion than a portal vein reperfusion, as long as the portal flow is intact. So you're actually prolonging your ischemia time by trying to do an arterial reperfusion.
Yeah, you really got the point there. We always do a slow portal, release. So I'm really not sure. It's been a very few cases that had experience when I was during my fellowship days. I'm really not sure whether that really helps doing the artery first. I think Prof wanted to say something, I guess.
Yeah.
Yeah.
You have a paper from decades ago with eaten with regards to the blue blood versus the red blood.
Yeah, this was a surgeon from New Zealand who wrote that, reperfusing with blue blood. Now, the observation when we suddenly started doing arterial perfusion, and it seemed very attractive for a period of time, we felt that, as Pari described, I think Pari said it correctly, that when you're worried about reperfusion syndrome, we did an arterial reperfusion. And he is absolutely right by saying that there is less reperfusion. And we felt that it was probably because we are putting a good oxygenated blood into the liver that these livers are experiencing less reperfusion. So that was my idea. And for some time we did. And then we did the study and then found it made absolutely no difference, even actually for reperfusion. I think the benefit of the arterial reperfusion was that it was actually the slow reperfusion rather than the arterialized blood that we were reperfusing the liver with. We discovered that, and that's when I changed to a very slow reperfusion through the portal itself rather than the artery. There's absolutely nothing wrong in reperfusing with the artery. As Srinivas said, if you're unsure about how good the portal flow is going to be, it is better also to do the arterial anastomosis and keep it ready. And in case the portal flow is very poor, you can open the artery and protect the graft. But to do it routinely is very cumbersome, actually. Even if you want to do an arterial reperfusion, you have to do the portal anastomosis. Otherwise, it's very inconvenient to have a portal clamp there, everything separated out, and then to do the arterial anastomosis first. Unless it's a DDLT and your vessels are all very long, particularly in the LDLT setting, it's very difficult to do the artery first, reperfuse, and then keep the clamps open. And then do the portal anastomosis. And the problem with portal anastomosis after arterial anastomosis, particularly in LDLT, is there is no stump on the graft side. So you can't actually clamp the portal vein well enough on the graft side because there'll be a back bleed once you have reperfused it. So actually in the LDLT, it's very cumbersome to do the arterial reperfusion. So as Srinivas said, then in that case, you've got to do the portal. Normally the portal anastomosis takes 5 minutes and then you're going to reperfuse. But if you want to do artery and portal, you're adding at least another half an hour to the cold ischemic time to the artery and the portal vein. And then you reperfuse. So finally, I decided to myself, it's absolutely of no benefit to do the arterial anastomosis. And also to do the arterial anastomosis very carefully and slowly after reperfusion and everything is settled is much better for the arterial anastomosis itself rather than hurriedly trying to do it to reduce the cold ischemic time in order to do the arterial anastomosis. I think even the way you're thinking about doing the anastomosis is better when everything is settled down. So I wouldn't recommend doing arterial anastomosis unless you have a problem, you think that there is going to be a problem with the portal flow.
Thank you for that, Prof. Prof, do you think that there's a higher incidence of hepatic artery thrombosis if you do an anastomosis early enough, immediate reperfusion?
I think so. I think there was some study and there were some problems to do the arterial anastomosis first. You know, I mean, there are so many little things that we discover when we change protocols. I'll tell you one simple example of something that you wouldn't even dream would be a problem for hepatic artery. We were doing a study of collecting bile during the retrieval. And we didn't want the gallbladder bile. We wanted to put a cannula and wanted to collect the bile from the common bile duct, and also during later on after there were many bile studies with it. So we asked the donor surgeons to cannulate the cystic duct and do a cholecystectomy in the cold phase, or not in the warm phase, in the bench in the cold phase. And you won't believe the amount of arterial complications we had when we asked people to do that. So even the simplest of the things can lead to problem actually with the recipient. So I think trying to do an artery before reperfusion, trying to bring it together when the arteries are very short is not that easy. It's not very practical to do the artery early on.
Thank you for that comment. Any other questions or comments from the forum? Dr. Pali, Dr. Ilango, would you like to add something? Dr. Reddy? You're muted, Dr.
No further comments. It's a good discussion. Thank you.
We have been at it as usual for 2 hours and 10 minutes now.
Can anyone talk about bile duct anastomosis in the deceased donor? An end-to-end anastomosis. Has anybody tried a long oblique anastomosis? Cut both ducts obliquely?
Like how
So,
you
your
do a
suture line is, pardon?
ureteric anastomosis kind of thing, Prof. Is that what you say?
Yeah. That's right. Yeah. That's a good way to do a side-to-side oblique cut. On the lower end on the right border and the upper end in the left border, and then make a very long anastomosis so you don't get a stricture. Has anybody tried that? I mean, I'm not doing it here, but they used to do that in the early days. I think Birmingham, if anybody's gone through Birmingham, they'll also know they used to do that. Just put a long cut, like a fish mouth on the recipient side, and then a fish mouth on the left border on the donor side, without cutting through the marginal vessel, the 3 o'clock, 9 o'clock vessel, and do a continuous long anastomosis. When you've got a bile duct which is very narrow to suture.
But then you would have one lip which is longer and maybe quite thin. So I don't know how the blood supply to that longer lip would be. Unless
No, I mean, as long as you don't cut through the, you can actually cut away from the blood vessel, slightly anterior to the 3 o'clock vessel and slightly posterior to the 9 o'clock vessel on one side.
Prof, can we do the same technique by doing the cut on the anterior and the posterior aspects so that we don't damage the 3 o'clock?
Yeah, you can do that. You can do that too. Absolutely. Instead of side by side, you can do the anastomosis from the right side and left side. That may be easy. I've not done that. I think it is a good idea to do that. It will be, and you could do it as a continuous suture then, because even if there is a slight tightness, the lumen will not be narrowed at all. You'll have quite a big lumen.
That's something to ponder about, Prof. I think we could work on that as a study, maybe like a case. Any other comments, Prof, would you like to make before we close the session? I can see Dr. is already dozing off.
No, not bad. I actually dozed off in the middle. I was worried that you might ask me something that I missed. Yeah, thank you. I think that was really good.
And thank you, Dr. Ilango, for the excellent presentation. Dr. Reddy, as always, thank you very much for being there. Dr. Pari as well, and Prof, as always, thank you so much for attending. And it's been a lovely session. I think we'll close it this week and meet again next week. Pata sir, would you like to make some comments?
Wonderful session as ever. It's one of the very good sessions I've listened to and mesmerized actually. So many pearls of wisdom for so many people to take home. Thank you. Thanks for the continuous effort, Ashwin. You have such a continuous flow of speakers, and you have a huge list of speakers ready with you anytime. I think we should continue this for as long as we can. Thank you. Thanks.